I'll be talking to you about the role of endoscopic ultrasound in the pediatric application. And I must confess to you that this is a kind of a little underutilized investigation. I think one of the things that we would like to, kind of emphasize is that we need to increase the utilization of endoscopic ultrasound in our pediatric patients. And as adult gastroenterologists, actually, we don't get much of referrals from pediatricians. Maybe because, first of all, there's non-availability of endoscopic ultrasound in many centers, but that's, of course, improving a lot now. Secondly, there's an issue probably of the impact on management. And I would like to highlight some of the factors where, the endoscopic ultrasound can really impact the management and your, management of these, the diseases in these children. And of course, there's a little bit of fear of complications of the procedure. So that is one of the things. And the other thing is, of course, pediatric gastroenterologists are not getting trained enough in endoscopic ultrasound. So that's another issue which is there. Now, if you look at the data, I mean, the use of endoscopic ultrasound in the pediatric population is actually increasing. And most of these studies are showing a very high impact on the management. So we need to actually improve, our utilization of this particular procedure. Now, as far as equipment is concerned, certain basic things, we have basically two types of equipment. One is the radial endoscopic ultrasound, where you get imaging like you get in a CT scan. So it's a 360-degree scan, and you get a cross-sectional imaging of the organ that you want to kind of evaluate. And you have the linear EUS scope, where you can take biopsies and you can do interventions. And of course, you have got mini probes, which are ultrasound mini probes, which can pass through the biopsy channel of the endoscope. So these are the three main types of equipment, of which the radial and the linear are the workhorses for us. The big advantage of endoscopic ultrasound over any other imaging modality is, of course, that you can see the wall layers extremely well. So you can make out the GI wall layers extremely well. And most importantly, particularly in the pediatric population, you can see the structures outside the wall, like the gallbladder, the bile duct, the pancreatic head, uncinate process, body and tail of the pancreas extremely well, the vascular structures, the ductal structures, etc., extremely well. So there is a lot of advantage of using EUS. Most of the scopes are Doppler enabled, so you can do Doppler. Many of them will have tissue elastography, so that was mentioned earlier. And many of them will have software to do contrast EUS as well. So they are quite good, and you get good imaging and very good information on various disease processes. Most of the applications in the pediatric population for endoscopic ultrasound will be in the biliary pancreatic diseases space. There will be a group of patients who will benefit in the upper GI US and very, very small in the Ano-Rectal. And I'll discuss all these three applications, briefly. So the first group of applications will be in the evaluation of acute or acute recurrent pancreatitis, as Dr. Neelam just mentioned. And biliary etiology scores very high in the adult population, but of course it is increasing in the pediatric population as well. And the reason why EUS is very useful is because a negative MRCP really doesn't exclude the presence of a bile duct stone causing acute pancreatitis. Particularly if the stone is less than 3 mm, MRCP is not that good. And you have a very high negative predictive value for EUS. So if the EUS says that there's nothing in the CBD, there is really no need for us to do a ERCP in that situation. So it's really, really helpful. And in fact, in the adult guidelines on acute management of acute pancreatitis, probably EUS is now going to go into the algorithm of, workup and management of these patients very high up. Again, you can get biliary microlithiasis as a etiology of acute pancreatitis. And if you look at the gallbladder here, this is a patient who had acute pancreatitis. Ultrasound really didn't show anything much. And you do a EUS and you see this small crystals, hyperechoic crystals in the gallbladder. It's called as a starry sky appearance. You're very sure that this patient has got this microcalculi causing acute pancreatitis. So very, very useful. You can even pick up pancreas divisum as one of the causes of acute pancreatitis. So in the normal situation, you get the bile duct, you get the pancreatic duct, and you get the portal vein, which is called as the stack sign. If you have pancreas divisum, you will see the pancreatic duct, the CBD, and the portal vein. So it's called as a reverse tag sign. It's quite sensitive, quite useful to diagnose pancreas divisum on endoscopic ultrasound. And of course, in some patients, you may need to add on a MRCP to diagnose divisum. Again, Dr. Neelam mentioned about chronic pancreatitis, and this is something which is actually increasing, almost one-third to one-third or even more number of patients with acute recurrent pancreatitis, particularly, will actually have chronic pancreatitis. And sometimes it's a real dilemma for you to diagnose that this patient of acute recurrent has actually got chronic pancreatitis. You may do a CT scan, which may be normal. One may do a MRCP, which will be inconclusive. But if you do an endoscopic ultrasound, you can really pick up chronic pancreatitis quite well. So you have got certain criteria which we have, which we call as the Rosemont criteria. There are parenchymal changes and ductal changes for us to diagnose that this patient could be having actually chronic pancreatitis. And you can add on EUS elastography quantitative if you have the software in your equipment to actually get to the diagnosis. So it's a very useful test to diagnose chronic pancreatitis in a patient with acute recurrent pancreatitis, particularly if the other imaging is not conclusive. Autoimmune pancreatitis, particularly the type 2 variety, which we see in adults actually, which you can get in the pediatric population also, is another good modality for evaluation as far as EUS is concerned. And most importantly, you can even take biopsies of the pancreas and prove the diagnosis by the biopsy. The biopsies for the pancreas is now actually improved. So we were doing FNAs, now we are doing FNBs. That is fine needle biopsies, and one of the reasons why that is possible is because just needles are much better, and you can get very good tissue from, tissue acquisition is very good with these new needles. One of the other big uses for endoscopic ultrasound is the management of peri-pancreatic masses, particularly lymph nodes, particularly in our situation, tuberculosis. Where you have peri-pancreatic lymph nodes, you can do a EUS, you can do a biopsy, and send it for histopathology, cytology, TB gene expert, etc. And as I mentioned, that the biopsy needles actually have now come, and they have really helped us in getting very good tissue. Solid tumors of the pancreas, not very, very important, but once in a while we do see. In fact, recently we did a 5-year-old child with a solid tumor of the pancreas with obstructive jaundice who turned out to be a pancreatic NET, which we proved on the EUS-guided FNAC or FNAB. Pancreatic cysts, again, is very good for EUS evaluation. Not much of pediatric applications, but once in a while, in female patients, maybe 10, 12, 15 years, you may see SPNs, that is solid pseudopapillary neoplasms of the pancreas, which can be diagnosed with the endoscopic ultrasound. The other big application for endoscopic ultrasound is the evaluation of dilated bile ducts. Very often you do a transabdominal ultrasound and you get a patient with a dilated bile duct and you don't know what it is. Is it small calculi? Is it a small tumor? Is it some worms, Helminthiasis, etc.? So there are a lot of causes of a dilated bile duct which you can actually pick up on endoscopic ultrasound, where the other imaging modalities may not help you to clinch the diagnosis. Portal biliopathy, again, is a good indication. We can see varices around the CBD, pericholedocal varices, or even sometimes intraductal varices, which we can pick up with endoscopic ultrasound, and it can help you in evaluation and management of these patients much better. I mentioned that in our country, one shouldn't, miss patients who've got roundworms in the CBD. In this particular patient, we had a liver fluke in the CBD, which we saw on the endoscopic ultrasound. There was a semilunar structure, did a ERCP, and we fished out a liver fluke. So it's really useful in many, many biliary pancreatic applications. As far as the interventions is concerned, again, as the previous speaker mentioned, the pseudocysts is one of the complications which occurs following acute pancreatitis or sometimes acute recurrent pancreatitis, even sometimes following chronic pancreatitis. And now the standard of care for pseudocysts is endoscopic management. The only thing which has evolved here is, of course, we puncture the cyst and then you dilate the tract between the stomach and the cyst, or the duodenum and the cyst. And many times, instead of putting a plastic stent, we now, particularly if the fluid is very thick, it's infected, we can put a biflange metal stent in these cavities, and you can, drain almost the entire thing in one session. So this is one of the cases where we've drained this, dilated it, and okay, and then this is the metal stent which is deployed. So this is a biflange metal stent, and you see that the drainage is very, very good following this kind of a procedure. The other thing that one can do is to do a direct endoscopic necrosectomy, and this is something that we are doing more and more, and in fact we've done 5 or 6 pediatric patients also where there is acute pancreatitis and there is a wall of necrosis in these patients, and you can use this metal stent as a port and get into the necrotic cavity and fish out large amount of necrotic tissue, and these patients would otherwise go for surgery. But now we can do what is called as a direct endoscopic necrosectomy. You do this procedure and you can get out and fish out all this necrosis and cause good healing in these patients. So that's these are the 2 main procedures, interventional, which we are doing as far as the pancreas is concerned, EUS guided. There is some role of doing a EUS guided liver biopsy. I'll not go into the details, but people are doing it, and this is possible. About the luminal applications for the esophagus stomach, you can do it for evaluation of duplication cysts. You can do it for evaluation of mediastinal masses and take biopsies. You can do it for evaluation of subepithelial lesions and take biopsies. Look at varices, particularly those which are not doing well, in the sense they are not getting managed, or the bleeding is not getting controlled with conventional treatment like glue. Evaluation of thickened folds, evaluation of eosinophilic esophagitis, and TEF also. So some of the applications, this is a patient with a duplication cyst. So you can see another cyst over here which is lined with the normal esophageal wall. This is in the esophagus. So you can get a clear-cut exact diagnosis, and you know that this patient has got a duplication cyst. This is a patient with a mediastinal mass, and there is a lymph node mass in the anterior to the esophagus with multiple hyperechoic specks. Just a minute more. And this turned out to be tuberculous lymph nodes in the chest. We biopsied it. Subepithelial lesions, lipoma in the stomach. You can make out between a GIST or a stromal tumor or a lipoma easily. Management and evaluation of thickened folds in the stomach you can do with endoscopic ultrasound. I told you about varices. In some patients, they don't do well with standard glue treatment. You can do EUS-guided cyanoacrylate glue, which is more precise. You can actually inject the glue properly, and also you can insert coils inside these gastric varices to manage them much better, so that's also possible. Eosinophilic esophagitis is another area which some investigators have used to evaluate these patients and then follow up these patients using EUS. Ano-Rectal applications are also there. You can assess the sphincter with endoscopic ultrasound very well, and some patients with fistulas, particularly in patients with Crohn's disease, can be managed or evaluated with endoscopic ultrasound. So it's very easy for us to do the assessment of the sphincter, external anal sphincter, internal anal sphincter, post-traumatic, etc. It can be evaluated even post-operative for that matter. And fistulas also can be evaluated. There is some role of 3D EUS in this situation. So, friends, ladies and gentlemen, that this is what I wanted to actually tell you, that EUS has shown to be very safe, effective, and it's integral in the management of the pediatric patients with both pancreaticobiliary and luminal diseases. And as I was mentioning to you, that besides many diagnostic indications, it is increasingly be used for tissue acquisition as well as an interventional tool. So thank you very much.
If anybody has any question.
I want to ask regarding one case that I saw a few days back. It's regarding 6 months old child that came to us with acute pancreatitis with pancreatic ascites, and that was following a trauma by her brothers stepping over her abdomen. Yeah. And the child developed traumatic pancreatitis, and CCT was suggestive of complete transection of the mid body of pancreas that was around 3 mm. Yeah. How to manage that child?
Yeah, so that as far as the role of EUS is concerned, you know, in a 6-month-old, you said this patient is 6-month-old, so of course there won't be much of role of EUS in this particular situation, because you know, already you know that the etiology is a traumatic pancreatitis, and the patient may develop a collection following that, and that can be managed endoscopically in that patient. So if it's a large collection, you can put in the stents and, hope that the thing resolves, and you may have to do a transpapillary ERCP also. But EUS, usually is done in children who are more than 3 years of age, and they should be at least 12 to 15 kgs, because what happens is that the scope diameter is a little big. So usually we will not do it in kids who are less than 3 years. So that's something that I didn't mention, but since you got this case, I just thought I'll tell you.
And should we go for ERCP with PDS stenting after doing an MRCP?
So the most important thing in the traumatic pancreatitis with the complete duct disruption will be to manage the collection. And you'll have to put the stents inside the large collection over there and then see how it goes. Sometimes we just put long-term stents. So you can even put a metal stent, which I said, in that patient if the cyst is very big. And then once the complete resolution of the collection occurs, then you can put plastic stents and just keep it for very long. Maybe a few years also, there's no problem.
Thank you,
The
sir.
basic point the young person is trying to make is that's a 6-month-old child, and it will be very difficult to do anything endoscopically at that weight.
Yeah.
And since it is a transaction, the prognosis is not so very good by the thing is. So basically, octreotide, TPN, and hope for the best.
Yeah. But we can do a drainage with a, side wing scope is possible. You can't do a EUS because there's not much role, but if there is a good bulge, you can do a side wing scope.
No, but he's saying pancreatic ascites.
Yeah. If there's a big collection which is getting walled off, then there is a role.